Welcome back, dear friends. I'm your host, Dr. Manjunath. I'm a pediatrician and allergy specialist based in Bangalore. Today, we'll be looking into a silent zone in the lung, which is making a huge noise in recent days. That's nothing but small airways disease in asthma. Yeah, before we go deep into this topic, please make sure that you subscribe to my channel. Also, make sure that you like and share this video as much as you can. Believe me, it takes a humongous effort to make these videos. To start with, we understand that asthma is a disease involving the medium sized and the small sized airways in the lung. What is this small airways? When the pathology of the lung is involved in the areas of the lung where the size is less than 2 microns is called the small airways disease in asthma. We all understand that there is element of both medium and small sized airway involvement in asthma. But whenever the pathology is mostly in the small airways, it is called the small airways disease. This was not a predominant thing before the advent of the oscillometry and many of the lung tests which we have been doing quite often. As we go more and more in the diagnosis, we have started to understand that roughly 50 to 60% of all the asthmatics have a predominant small airways disease. This affects how they present to us in our clinic. These patients tend to have more symptoms. They tend to have more nocturnal cough. There is more dyspnea. But when it comes to signs, the signs and symptoms have a complete disproportion. They tend to have more symptoms than the asthmatics. Why? That is because the pathology, what is typically seen in asthma, is a goblet cell hyperplasia, subendothelial fibrosis, mucus formation. All of them are the same, whether it is the asthma or with the predominant small airways disease. Since there is no cartilage to hold these airways patent, they tend to collapse. Whenever the collapsibility happens, there is more and more air trapping. There is ventilation inhomogeneity, and the hypoxia levels tend to be much deeper in patients who have small airways disease. As I have been saying, there is air trapping, and ventilation inhomogeneity leads to that severe symptomatology compared to the signs what we see in these patients. And how do we make a diagnosis in the bedside? Well, that disproportion in the signs and symptoms should give you a clue that something is wrong with these patients. We should be looking at more than just asthma, where it involves the medium and the small sized airways. We should have that intuition and the astute mind to think that this could be a small airways disease. And our spirometries, they give you a clue. The parameter, that is FEF 2575, very low FEF 2575 will give a clue that okay, this patient might be suffering from small airways disease. And very low FEF 75 will also give you a clue. And FE3 by FE6 values are very low in these patients. So these are the parameters which will give you a clue that this patient may be suffering from small airways disease. But the unfortunate thing with spirometry is there are no real standardized values for us to call that this is a small airways disease or just a simple asthma what we are dealing. So it is the oscillometry which will give you an idea that we are dealing with the small airways disease. The parameter, that is R5 minus R20, a significant increase, that is 0.07 kilopascal per liter, that is a real indicator to say that this patient might be suffering from the small airways. And other thing is much pronounced X5 values and much pronounced AX values will give you a clue that this patient is suffering from the small airways disease in asthma, not just the asthma. So, what are these patients? Irrespective of the type of the phenotype you have, it can be either a T2 high with the atopic or a non-atopic asthma, T2 low asthmas, neutrophilic asthmas, eosinophilic asthmas, whatever the type of endotype and phenotype you have, you might still have a predominant small airways disease. Remember, it is a pathological diagnosis, pathological understanding of the disease, not the phenotypic or the endotypic classification. Irrespective of the gender, irrespective of the age, a lot of patients tend to have the airway involvement in those areas which are less than 2 millimeters. After you have made a diagnosis on the bedside, do we have any further tests? Like you have plethysmography or the CO2 washout studies. These will give you a real understanding that this is predominantly a small airways disease. Well, you made a diagnosis that it is small airways disease in asthma. Do you have anything more to offer? The answer is yes. Well, the current inhaler choices, what we are seeing in the market, have a mass median aerodynamic diameter of 2 to 5 microns. These ones are not capable enough to enter into those less than 2 microns in size and give you the anti-inflammatory benefit what is needed in these patients. These patients need inhalers where the ultrafine particles of particle size less than 2 microns consistently available for the terminal bronchioles where the action is needed. And the next question what we have to answer is, do we have such inhalers available in India? The answer is yes. Currently, we have cyclosinide which is available in the market at 80 micrograms, and that is having ultrafine 2 microns in size, and that is a beautiful drug to deliver through inhalers and even through the synchro breathes. They offer fantastic relief for those patients who have predominant small airways disease. What's the catch here? When you have the treatment, why don't you give it? The thing is, it is licensed for children over 12 years. As a pediatrician, I have those limitations that I cannot offer it to every patient. Other thing is, it is not available in the form of with LABA combination. So I'm limited to give it to those children. Whenever I have made a diagnosis of small airways disease in children who are more than 12 years, they don't need extensive treatment even with the inhaled corticosteroids with LABA. Those are the patients I can offer it to this cyclosinide. The other thing is, other molecule which is available is with the beclomethasone combination with LABA. But the unfortunate thing is, this molecule is called Nivioli from Cipla, is to be refrigerated. Now you cannot. Many of the pharmacists don't want to keep the inhalers in their refrigerators. It's going to take up a lot of space, so they just don't want to keep it. If it is kept out of a refrigerator, the shelf life of that molecule is very less. For these reasons, there is a limitation. Another big limitation, what this ICS with LABA combination, what is available, which is again a beautiful drug with beclomethasone, is licensed for children over 18 years in India. That's a huge bummer. We cannot give it to our children. But of course, in other countries, beclomethasone is licensed for children over 12 years. Another catch whenever you are using beclomethasone is the bioavailability, which is considerably higher. That's roughly about 36%. That means a lot of drug what you give through the inhaler can get absorbed into the system, and probability of the side effects also go up. So these are the things what you need to keep in your mind whenever you are treating children with small airways disease. Is there any hope? Well, of course, the CIPLA is coming out with the newer technology where the budesonide formoterol combinations what are available in the name of Furocort, where they have planned to have at least 50% of the molecules available at 2 microns in size. So that means it is beneficial for a large group of patients. Whether you have the medium and the small sized airways or a predominant small airways disease, this molecule would be a game changer in the management of asthma. So, what are the key takeaways of this session for today? The key takeaways is yes, there is a separate entity called small airways disease, irrespective of the phenotype and endotype you present with. They tend to have much severe symptoms than the regular asthmatics what you see. Diagnosis may be a little tricky because the spirometry, which is a gold standard in diagnosis, may not be of much benefit because it is not standardized values. Oscillometry, the device is not available in most of the places, and many of them are not capable enough to understand what the results you get in oscillometry. Once you have made a diagnosis, you have treatment options available in the country which will give the relief for these patients. With this, I'll be signing off for today. And again, a big thank you for staying in this long. Also make sure that you subscribe to my channel and share this content as much as you can. Thank you. Bye-bye.